So, providing accurate, helpful health and safety guidelines to the public during a pandemic, one that is being caused by a new and very fast changing virus, is not easy. I am joined today by the director of the CDC, Dr. Rochelle Walensky, and we'll be talking about how the CDC makes its decisions about COVID-19 guidance and messaging. Dr. Rochelle Walensky, thank you so much for being here with us today.
Thanks so much for having me. I'm delighted to be here.
So let's just dive right in. You have clearly inherited an incredibly difficult job at a very challenging point in our country's history. Tell me a little bit about what the toughest parts of the job have been so far and what has surprised you the most.
I once had a very wise mentor who said to me, if you're not a little bit afraid of your next job, then perhaps the job isn't big enough. And so I took that with me when I came here. I was a little bit afraid of this job, and certainly it has been a daunting task in the middle of a pandemic. It's been hard. I inherited an agency that is full of people who have been working tirelessly for the last 18 months to protect public health, that is all doing much of their work remotely. So getting to know the people who are doing that work has been hard, diving right in and recognizing so much of the future of the public and public health rides in the hands of this agency. And, I've taken on the task with that work in hand, and really feeling a great gift of inheriting incredible people who are working every day and night, literally, to make sure the public is safe.
Definitely. So I'd love to talk a little bit about your decision-making process, which has, by definition, had to be incredibly fast-paced and not always clear-cut in every single direction. You and your team have been repeatedly tasked with collecting and analyzing a very endless flow of data that's often imperfect and being collected in real time, and then making really high-stakes decisions for the public good. How are you balancing timeliness of these recommendations with sticking to scientific rigor? During a pandemic, what counts as enough to make a big sweeping recommendation, especially when data might conflict or when many of the experts are disagreeing with each other?
Yeah, that's a really important point. And one of the things that I think we've done, just even since I've been here, is to understand and try and anticipate what are the questions that people are going to be asking a month from now, 2 months from now, and what are the data that we're going to need to be collecting now in order to inform those decisions. Sometimes the data aren't as if we would want them, or they appear to us, they come to us and we say, oh no, is that really what's happening? And maybe I'll sort of take the description of what happened in July when we saw breakthrough infections from Barnstable County, Massachusetts, these breakthrough infections. So back in March, when we said vaccinated, or I should say in May, when we said vaccinated people could take off their masks, we had the Alpha variant, and we saw if you were a breakthrough infection with the Alpha variant, you actually couldn't transmit to other people. So fast forward, in July, we had the Delta variant. We anticipated the vaccines would be working just as well. And in fact, they have been working well to prevent infection. But what we first saw in this Barnstable County outbreak was that the viral load was actually just as high in people who were breakthrough infections. We saw those data as the outbreak investigation was actively happening, literally. And we saw it on a weekend, and we said, wow, that would be different. And that would be policy changing if, in fact, this is what is happening. We didn't necessarily want to make those decisions on a single outbreak, so we reached out to our colleagues who were doing other outbreak investigations. One other county across the country was doing a similar investigation and actually found a similar thing. We reached out to international colleagues, and they were just starting to see data that showed something similar, all within a weekend. So we knew that we needed to move. We knew that we needed to change a policy because these were corroborated in several different places, literally in real time. And then we really knew that we needed to publish the data almost immediately so that people could see the data upon which we made those decisions. And that is some of the speed that we've had to be able to review the data and to make new policy decisions.
Great. Yeah, and I think we are now in a somewhat similar situation with a little bit of messiness with the recent guidance on boosters. Given what has come out of the White House, VRBPAC, the FDA, ACIP, and your own announcement that came out last Friday, I think some people are feeling a little bit confused, maybe even a sense of whiplash. I think very recently, your own recommendation to greenlight high-risk workers for boosters was not what the ACIP advised you to do. Tell me a little bit about how much of that was based on what data was available available at the time, also knowing that, the public had been told to expect something very specific about who would be eligible and recommended for boosters. How did you balance those two things?
Right. So back in August, we have now set up a way to review our vaccine effectiveness data in real time, every 2 weeks or so from all of our cohorts. And that has really been helpful in informing where we need to go. In August, we started to see data that demonstrated some waning in infections. And so we knew we needed to plan, and we knew we needed to publicly plan because the data were going to be published. We've been talking to our international colleagues as well. And that's really where the planning phase had begun. We've been planning for the last month or so to make sure that when the data were available for boosters, that we would be ready to go. So fast forward, we had more data, this week, and the package went to the FDA. The Pfizer BioNTech package went to the FDA. Again, our booster announcement was for people who got Pfizer. And the scientific process worked. There's a vaccine advisory board to the FDA that met with scientific deliberation. The FDA authorized it. My vaccine advisory board, the Advisory Council on Immunization Practices, met, and they gave me advice, and then I made some recommendations. And for the most part, there was a lot of consensus. So after listening to all of the science, I fully endorsed vaccine boosters for people greater than 65, for people who live in long-term care facilities, and for people who are at high risk of severe illness. So people with underlying medical conditions. And where there was a scientific close call, I listened to the science, and I ultimately ended up going with and fully in line with what the FDA advisory panel said, and what many in our CDC advisory panel said as well, which was to endorse boosters for people who are in high risk settings because of where they work or live. So these were our healthcare workers and our occupational, our grocery workers, our frontline workers.
Yeah, to clarify that point a little bit, the language in these recommendations was very specific. There are certain people who should get boosters, and that includes the over 65 crowd, older groups with comorbidities. And then there are people who may get boosters. What's the delineation between being recommended to get a booster and being allowed to? And, what's the qualitative difference here between that and just kind of greenlighting boosters for everyone?
It's really the strength of the scientific evidence. Really, the strength of that evidence said we really should be recommending this. You absolutely should be recommending this. And for the people who we said may for, the people who live and work in high risk conditions, we're really, weigh your risks and benefits, understand what your own personal risk is, and make a decision based on that personal risk. Consult with your physician, consult with your pharmacist, consult with your public health officials, so that you can identify whether that you're in a place that a booster is right for you.
Yeah, I think a couple of follow-up questions to that. That there was a lot of data sort of breaking down vaccine effectiveness against the sort of different tiers of protection. We have more severe disease, hospitalization and death, all symptomatic disease, any infection whatsoever. And, it's been clear from the beginning that the public health priority is certainly to focus on the absolute worst outcomes, knowing that that is where vaccines are going to hold out the longest. What are you thinking at this point in terms of what boosters are going to do for the populations they've been greenlit for? Are you most worried about infections, some symptoms? Where can we actually see the biggest bang for our buck?
I think that this is exactly where the scientific deliberation was during all of these FDA and CDC vaccine advisory meetings. Our clinical trials were evaluating symptomatic disease. So it didn't create the bar of you have to prevent severe disease or hospitalization. You actually just had to prevent symptomatic disease. And so really the question was, do we have strength of evidence now for third shots that we should just be preventing symptomatic disease, or that we should really keep the bar and you have to prevent some severe hospitalizations and deaths? And there's equipoise in that question. We don't, some people feel strongly one way or another. What I will say is in our flu vaccination, we vaccinate people to prevent symptomatic disease. We have have more experience with flu vaccines. We have longer horizons that we've been giving flu vaccines over years and years. But there are many people who very much believe, and I'm among them, that we should be preventing symptomatic disease because, in fact, there are long-term consequences, or because it keeps people out of the workplace, because even moderate disease can actually be pretty severe and debilitating. So there's a lot of equipoise in that question at this moment.
Sure. I mean, it's interesting that you bring up the example of the flu vaccine, which we know, please correct me if I'm wrong, tops out with effectiveness around 60% most years. It's a great vaccine. I got mine about a week and a half ago, and I'm very glad for it, but it is certainly not perfect. And it seems to be not as good as the COVID-19 vaccines we have. Why boost now if our vaccines seem to be holding up quite well against that, especially against very severe disease, hospitalization and death?
Yeah, it's a really important question. So I think some of the reasons that we need to be boosting now is because we are starting to see some people over the age of 65 in some cohorts, over the age of 75 in other cohorts, that are having waning associated with the vaccine, or perhaps associated with the Delta variant, and are landing in the hospital. And so that is the reason we feel like those especially vulnerable cohorts merit a boost at this moment. If we can prevent those hospitalizations, we've seen some deaths in people who are vaccinated. Generally, the mean age of those deaths is around 80. So if we can give more protection to those people, there are many people who have believed that this was always going to be a 3-dose vaccine or a multi-dose vaccine. And really, many vaccines that we have, our hepatitis B vaccine is a prime and a boost at 6 months. So there are many vaccines that follow this schedule. But you're right, and I think one of the important places that you're right is, flu vaccines in any given year are about 60% protective. We have wanted, yearned for a golden bullet COVID vaccine. And I think we have to manage our expectations of what a vaccine can do during pandemic times. And even though vaccinated, have to take the proper prevention measures.
Right. So, my understanding is at this point, under your official recommendation, which you gave out on Friday, you are now included in a group that may get boosters based on individual benefit and risk. Are you planning to? And, how would that situation have changed if you had stuck to the original recommendation from ACIP?
So am I planning on getting a booster? I am planning on getting a booster. I am not at high risk myself based on where I'm working right now. Much of the government is remote. So I am, when I think about what my occupational risk is, if I were seeing patients still in the hospital, I would absolutely get a booster. And so I intend to. I want to make sure that people who are in higher risk categories than myself, I'm not crowding them out, but I intend to.
Got it. I think sort of following that logic, you sort of gamed out for me, your own risk benefit analysis just now. And this is what I think you and many others are asking people to do at this point. But I do want to point out here that a lot of the guidance so far has focused on very individualistic rhetoric, which is very tough for people to internalize at this point. Boosters protect you, masks protect you, your health is in your hands. I think you've even said in the course of this conversation, people are being asked to weigh individual risks, individual benefits. How do we square that with a risk that is entirely communal, knowing that so much of the world remains entirely unvaccinated? Are we balancing the right metrics here, individual versus communal?
Yeah, I think that that's actually a really important concept. And many of our vaccine guidances have focused on the individual. Many of our is from an individual standpoint, are your risks, are your benefits greater than your risks? And we get a lot of vaccines for that. But I do believe that we also have to take into account the societal benefits. So in addition to that healthcare worker not being sick in bed, perhaps getting long COVID, or being out of work for 2 weeks. If that person's out of work for 2 weeks, that could be an ICU bed that can't be filled because they don't have workforce. And so I think that there are real, tangible societal benefits from so many people being out of work. I say that also for teachers. There are school systems that are having to close schools because their teachers are out sick. If we can prevent those from happening, not only do you prevent individual illness for that teacher themselves, but also, can potentially keep a school or a classroom open.
Do you think the boosters are going to have a substantial impact on transmission?
I have frequently said we are not going to boost our way out of this pandemic. We need to get unvaccinated people vaccinated. We have, to this day, in hospitals, even with waning, even with Delta, the people are you're tenfold more likely to be hospitalized if you are unvaccinated, and 11-fold more likely to die if you're unvaccinated. And so really, yes, we need to optimize the protection for people who are vaccinated already, but we really need to, in addition, spend time, energy to get the unvaccinated vaccinated. And I mean that here in the United States, and I mean that around the world.
Yeah, and I absolutely agree with that. I do wonder what the past couple weeks, really past couple months of conversations over boosters, which are explicitly shots for people who've already gotten some vaccines, what message does that send to the unvaccinated? There's a lot to be confused about for, I think, everyone. Seeing top health experts disagreeing immensely over recommendations, what effect does that have on public trust, especially when we're still trying to get first doses to people who have not gotten any?
Yeah, I think right now, the people who remain unvaccinated, we have to roll up our sleeves. We have to get into the communities. We have to understand what it is. This is not, the unvaccinated population is not uniform. There are people who have been waiting for more data. So let us present the data that we have. We have over nearly 6 billion people in the world vaccinated at this point. We have over 180 million people vaccinated here in this country. We have extraordinary experience with this vaccine now. So let's present the safety data. What are the questions of people who are unvaccinated? What is it that they are worried about? And right now we have to do that from trusted messengers. We have to inform people and give them the information that they need. We have to meet people where they are. This is not about blame and shame. This is about help me understand what has made you reluctant, you personally reluctant, and let's get to a place where you feel less reluctant. And even if that conversation doesn't result in your rolling up your sleeves today, it may be one step closer to your rolling up your sleeve tomorrow. And that's hard work.
Definitely. So to follow up on that, another question about meeting people where they are. I think in recent days, especially, we've heard a lot of complaints and confusion from people who got the Moderna or J&J vaccines, including many in older and high-risk groups who have now, gotten on good word from federal officials that they are in high-risk groups and maybe in need of boosters, but they have no path to get them. To my knowledge, even J&J recipients who are moderately to severely immunocompromised haven't been greenlit for boosters. You talked earlier about making decisions based on limited data, which sometimes has to be done. Why aren't we making faster moves on this front, knowing that sometimes it's better to advise in advance of all of the data?
So that's a great question. First, the severely immunocompromised, we created a pathway for that several weeks ago. So those people, people like bone marrow transplant patients, cancer patients, organ recipients, all of those people now do have a pathway to be boosted. But your point is well taken. And what I want to say is, this is a walk, don't run situation to go get your boost. The vaccine effectiveness is still working really quite well. And we are now doing the scientific diligence to make sure that we can review the data so that we can bring it to you before we get into trouble, but really after due process. That is happening in real time. Moderna is coming, J&J is coming. It will come to the FDA and they will treat it with urgency, and then it'll come to the CDC. We will treat it with urgency. And that will come in the next couple of weeks. So, what I want to reiterate is we want to do the scientific due diligence, because if we rush it, it looks like we haven't done that scientific due diligence. And we're doing it to get ahead of the virus. And that is exactly what we're doing. We have not forgotten about J&J and Moderna. We will be with you.
Great. And final question here. Hopefully we can end on a positive note, but I want to ask what you are optimistic about. We have a lot of big moves on the horizon, hopefully an EUA for kids under 12, the rollout of mandates that might get more unvaccinated people vaccinated. What are you hopeful for, and what is the spell for the coming winter?
Certainly, this virus has been humbling. So I want to remember all of those twists and turns that I have had over the last literally 18 months and said, well, I think, this may be a really bright step out of it. I do think that we have some really bright steps. I can see a future where we have the majority of the public vaccinated. We're working to vaccinate other people around the world, that we are optimizing boosters or optimizing vaccine effectiveness with boosters here in the United States, where children are starting to get vaccinated and feeling really comfortable being back at school. I absolutely can see those times. And what really gives me hope, and there's been so many challenges with this and so much dissension around it. But the things that I find beautiful are where people have really come together in the spirit of helping one another. And those stories are fewer and far between, because I just don't think they make the news as often. But having worked on the front lines for a year before coming to CDC, and now working squarely in public health, and seeing so many ways that the communities are coming together to help one another, I think is truly inspiring.
Thank you so much. Dr. Rochelle Walensky, we really appreciate you being here with us today.
Thanks so much for having me.